if there's anything you continue. If there's anything you'd like to discuss with me, feel free to join at the end or intervene with a hand wave. I'm happy with that. But I was asked to speak to you about inequalities, and I've given this title because I think it's quite a complex issue, and different people are looking at it through different lenses. Just briefly a bit about myself. Oh, there we are. It's popped onto my screen. Just briefly, I'm an interdisciplinary researcher. I won't go through all this list, but like probably other people that are in the audience today, I've come through to this field that I'm working in today through digital health through quite a circuitous route. And I'm quite happy about that because it's brought together a number of different disciplinary perspectives that have really helped me in understanding some of the challenges and opportunities and questions around digital innovation in society in general, as well as in healthcare. So I have a background initially in psychology and studying a quantitative psychology, and then moved on to his lecturership in psychology and started moving into more social psychology and other kinds of applied psychology, moved into applied health services research, initially applying psychology to look at group dynamics and the process of evidence generation, which led me into health technology assessment as a field and public health and a whole new set of skills. And then I moved into lecturing in psychology in a school of medicine, developing expertise in particularly, as it happens, in health technology assessment applied in the context of what is now known as digital health, which was health informatics in those days. And it really took my imagination. And then I moved on to setting up a digital health group at the University of Edinburgh about 18 years ago now. It's quite a long time. It seems like yesterday. And I've built that up over time and collaborated with many other super people to develop these programs and co-founding various educational programs, including the NHS Digital Academy, which is for NHS clinicians and other practitioners looking to develop leadership skills in this program. Indeed, Oma that arranged this event today was one of our graduates, so that was absolutely wonderful. And I also do various work with other external bodies, most recently with Scottish Government around digital ethics, and currently with the World Health Organization in digital health and primary care, and also the European Centre for Disease Controls around digital disease surveillance, and various other related works in other organizations, including those dealing with health workforce, for example. So all of those skills, including data science, which is the new kid on the block, have all kind of come together. And so my message is really, you are what you do, not what the label says. And that is really, for me, a healthy thing in the field I'm in. And I'm going to stop apologizing about not being a clinical doctor now. So just a background on digital health. I'm not sure how familiar you all are with this other than the headline, but just here's a quick overview of what we mean when we talk about digital health. It's anything from big information infrastructures and systems and networks, big machines and databases, and things for doing administrative work, things for gathering scientific evidence and developing knowledge databases, things for disease surveillance and coordination, different types of software and tools for doctors and other clinical staff to use in their professional practice, and for the consumer online health information, links to different types of resources, and increasingly consumer-orientated apps and wearables. And there's also the use of big data, which is from everybody, and small data for small groups of people, for example, or individuals or particular devices for helping to support your own healthcare, also public health, and to develop innovations and inform government and all the rest of it. And then there's a whole branch of emerging innovations we're seeing around robots and artificial intelligence. And sometimes they're the same thing, and everyone's tremendously excited about those and the mobile apps and so forth. And alongside that, there's a whole lot of what I was calling naturalistic digital health innovations out there, and digital health phenomena, if you like. For example, the use of social media for ordinary people as well as experts to post information, ask questions, develop solutions. And really, it's a fairly democratic way, but we know from examples of things like fake news around COVID that it can go wrong. So it's also opportunity with a flip side, and many more innovations. So really, I just want to get that out on the table. There's lots of things that digital are doing, and different ways in which the elephant, you can look at the elephant, if you like, to understand how digital would affect people, and by extension, how it can help to improve or potentially worsen health inequalities. And as with other areas of research in health and so forth, the framing of people in digital health is telling, and you hear different languages and different terminologies depending on who you speak to, which literatures you're going to, which websites. So there's a patient, consumer, citizen, user, people, communities, families, persons, or individuals. And so, those have different connotations, which have different implications digitally. Likewise, so is the imagery. This is digital health, for example, just from a search. This is a classic. We always see these pictures of people kind of engaging with these kind of 3D virtual reality tools. Usually doctors are seen in these images of digital health, and it's all very futuristic, but it's trying to create the idea that there's a world out there beyond the internet, and that's supporting decision making. This is what you get when you look for digital health and patient. Similar, but loads of iPads and mobiles, all about doctors sharing information with patients. And I suppose that goes with the territory, because a patient is in a clinical encounter, but nonetheless, not terribly inspiring. And when you get to consumer, it's a different picture altogether. What we see is a dominance of industry narratives, a dominance of market research. So consumer is sort of being left out of the picture when it comes to, or to some extent, certainly in terms of the world of Google, when it comes to representations of people like you and me, people who consume services, people who are recipients of care, people who also are citizens wanting to remain healthy. And we have been marketized to some extent and turned into these kind of commodities. And that is also quite telling. Just a little aside. But back to inequalities. Well, I don't need to tell you this, but inequalities are both endemic and entrenched and hard to nudge, but also modifiable. And that is the challenging area, is how much latitude do we have to modify them? How easily can we modify them? And then many policy initiatives being tried over the years. You'll remember some like the Big Society, and the current one is the Levelling Up strategy. It's all about reducing inequalities, often in the latter case to do with geographic inequalities, but also social inequalities within regions or cities or even areas. And health inequalities parallel other economic inequalities and social ones. So, the poorer you are, the further you are down in the social hierarchy, the worse your health is. And, there's a bit of a chicken and egg thing there, but nonetheless, we can't ignore the fact that these all work together, and you can't address one without addressing all of them. But digital health has been heralded as an opportunity to create fairer health access, and through fairer health access, better outcomes and more level outcomes. The idea being that we create more accessible tools that are available to us, and we are able to overcome some of the barriers that might have been in our way, for example, night shift working, or a lack of, in many countries, money to pay a doctor. And this would create these fairer outcomes. But there are also, just as with other types of inequalities, many barriers to realizing this vision. And one way of thinking about these is through the different lenses or faces of digital inequality. And I'm going to discuss a few of these with the Ds mentioned earlier, just because it's convenient to think about it this way. Deprivation, devices, data, deception, diversity, disruption, democracy, and dialogue. So we've already discussed social inequalities and deprivations. We know we have unequal society and health outcomes. And those inequalities may be local, regional, national, or global. And COVID-19 has turned the spotlight on all of them. And there's a lot more awareness, I think, of the impact that it can have actually not only on the health of individuals and particular groups, but actually on the world, on governments, on government spending. That inequality is a major problem. It has negative outcomes, which are not only social, but also economic. So that is what makes policymakers stand up and pay attention when that impact is affecting the bottom line. And I think more recognition that if we spend more on reducing or eliminating inequalities, we will actually stand to benefit. And of course, there are many other discussions around this topic. For example, most countries that were successful in tackling the pandemic had universal health coverage. And other countries, didn't. People were reluctant to pay for care or to, lose their wages, for example, if they didn't have a furlough. So these are important factors. And I'll come back to that. The other is devices. Now, innovations like mobile phone apps have been promoted as a solution to inequality, giving people without the ability to pay for healthcare a way of obtaining it remotely or via automated tools, increasingly artificial intelligence and synthetic doctors. But is it working? Well, the findings are mixed so far. It partly depends where you live. The business proposition, if you like, or the value proposition is different. So if you live somewhere where there are no doctors, it may be a lifeline. You may be in a very, poor country where there are, 2,000 people to one doctor and large distances to go. And so having something on your mobile phone may be a lifeline in a way that it wouldn't necessarily be if you actually have a human being nearby. The value benefit is less. And likewise for people, I guess, in remote and rural areas, even of the UK. But digital inequalities may also unintentionally expand the social and global health divide. Rather than those people who already have access to technology and those people who do not, but not just access, also skills and empowerment and education and all of these types of things that improve your ability to seek, find care, as well as some of the things that affect your own self-care and lifestyle, because some of those may not be in your control. So if we are using digital tech, and that's quite expensive, we have potential to actually expand the divide, because those who have the technology are often the ones who also have the better education. They also have the better healthcare to start with. They're more economically empowered in the first sense. They may feel a sense of entitlement over to receive healthcare that other disempowered people don't have. So while you may get a net gain, that gain may be felt the most by those who already have the most. And this is very similar to the inverse care law has been discussed in public health for a long time, that those with the greatest need are often least likely to be able to get healthcare when they need it. So this is the challenge for us. So how can we avoid that happening? Now, obviously, enabling digital inclusion is the key, and that's the buzzword in this field: digital inclusion, digital health inclusion, involving people, reaching out to them, making sure they have access to devices. We saw the move to bring laptops into children who are out of school in the pandemic, for example. But it can also be problematic. There's no point in giving someone a laptop if they can't afford broadband access. You also have to provide them with that. Otherwise, those laptops will just sit there doing nothing, for example. And you also need to give them the skills. And, there is something like a number of tools like the NHS Digital Inclusion Guide, which are all about trying to create strategies for enabling and empowering people so that they will derive these benefits. And there are other things like putting things in libraries, in kiosks, putting them in the supermarket, and using SMS. And one of the key messages that's come out of all of this work in digital inclusion worldwide, particularly when it comes to health, is a simple one, that relying on all the fanciest smartphone apps and all the super sexy tech bro innovations is not really very useful, because most people don't have that. And actually, your most effective interventions may involve simple SMS message on an old-fashioned phone. And you might have seen some reports recently talking about the rise in the use of old flip phones. Nokias are back in fashion, even among the very tech savvy, mainly as a time-saving device, because people don't want their attention to be drained the way that it is on a mobile phone, which is a computer in your pocket. But it also may herald a change to more acceptable use of this amongst other people, and more focus on these sorts of frugal innovations amongst those designing digital health tools. So, but nonetheless, there are these excellent devices and wearables and tools which are being not only bought by consumers off the shelf, but also prescribed to them in some cases by their doctors in order to self-monitor themselves and so on. But this does create a sort of inequality in terms of purchasing power and these other factors that I've mentioned. Another theme around inequalities has to do with data, and there are actually many issues in the field of data, health data science and health data research and so forth, which, you know, I won't have time to talk about, but let's just think about a few. The expansion of big data infrastructure and the linkage of multiple information sources, combined with innovations in things like spatial analytics, machine learning, they're helping to shine more light on inequalities associated with variables like location, age, ethnicity, lifestyle, and financial status, even your shopping habits. So those are creating opportunities to understand inequalities. And that's maybe a very good thing, to understand where people are, you know, experiencing the most illness and what is likely to cause it. It may help you to inform policy interventions that can actually target those sources of inequality and somehow ameliorate them. But is that happening? Insights are not enough. With insights also come obligations to act. Can we afford these things? Is there the will amongst the policymakers to shift a budget from a very expensive program that it's quite sexy and they really like it, high-speed rail, for example, into something that is really quite boring, fundamental, is likely to cost money for a long time, like, you know, subsidized food, for example. And you know, the same as we get these more precise and more predictive insights about the things which generate inequalities and which therefore call for interventions, we are under obligations to do something about it. And I suppose there is still a gap there, because not everything's feasible and not everything is politically expedient. So we need to deal with that. But around data as well, that's more the kind of e-government side of data. Using data, all of this data also raises many, many different ethical issues. For example, the more we know about, you know, communities, right down to sort of small level communities, although they're supposed to be anonymized, but are sometimes hard to be, up to society as a whole, can we avoid using this data about inequalities and, you know, the sort of gender and racial profiles of people who are more unequal or less less healthy? Can we avoid using this data to blame individuals or communities for being ill or for costing the state money? For example, you may have more alcohol consumption in a certain area, which also has deprivation. Do we blame the people for having ill health? Or is actually their alcohol consumption a function of their deprivation? So it's not just taking that away might not necessarily do the job. Are we ending up in a nanny state, and a nanny state that, you know, perhaps is not necessarily making good judgments? Or can we actually turn that into something healthy and useful and societally enriching in a way that's fair and ethical? Connected to that, you know, the poorest in our society are often typically those people who are the most datafied based on their interactions with benefit systems, housing. They may have been in the social care system. They may have greater levels of interaction or usage of healthcare services or medicines, for example. So they're most datafied. There's a lot of information about them. So one could say that, in a sense, if that's used very positively about those individuals in order to optimize care to them, in order to help to inform them to become sort of healthier, and all the other things that are associated with that, that may be a jolly good thing. But what happens if we end up with what we might call a digital privacy divide? Are those people with the least economically advantaged, are they also going to have the least privacy? And when we look again also at other things like apps and digital devices, this is also critical. We see more and more free tools being tools that are only free because the reciprocal payback to the company is that you share your data. Whereas if you can afford to pay for the tools that are not free, they may guard your data, and that may be part of what you're paying for. So not only is it this sort of big data and this general digitization, but also this purchasing power, which I think it has potential to really, really increase this digital privacy divide. And I hope some of the new legislation around online harms and digital markets and so forth can help to deal with that. But so far, I'm not convinced. And I think this is needing to be looked at a great deal more. And then finally, if all of this data is used for good, for public benefit, that's wonderful. But there is potential for information systems, to be used by people that may be not trustworthy or have vested interests or have ideological biases, for example, in which case they may become a further instrument of control or coercion. One that was controversial in Scotland at one point was the named person scheme, which was actually about people, school teachers and things recording things about children on a secret database. And this was where it was presented in order to, for the very good purpose of making sure a child at risk, was identified early. But it became quite dystopian, and other things we've seen around that are quite similar. So I just bang on about that a lot because data and data ethics are a big thing I've been looking at over the last decade or so, and I it is critical form of inequality, potentially a potential lever or potential cause of inequality. And that brings me to another issue of starting with D, the deception. And this, you can't see this picture very well, but there's someone with a mask. There's several types of deception in this field, not all of which are as closely related to inequalities as others, but I think they're significant and should be mentioned. For a start, huge sums of public money are being invested in the physical and algorithmic digital health devices, infrastructures and so forth, and also other kinds of money in society, and that swirls around our society and from individuals and from their pension funds and so forth. There's a lot of money going into digital health, but the business case is not always that sound. For example, companies that have promised to have a doctor in your pocket, it's actually proven fairly disappointing or potentially unsafe, or that promise, fingerprint blood tests instead of a proper visit to the doctor, and you could do it in the pharmacy and it would save everybody money and time and convenience. They haven't worked successfully, and there's been really some quite newsworthy cases that have forced us to reevaluate whether that funding is worthwhile. And likewise, some of the spending on major initiatives we've seen in COVID, have they produced value for money, or could that same application of money have perhaps been used better elsewhere? I think we're getting a bit smarter about, being honest about those propositions when they are put forward, but it still remains an issue, and there's potential to disempower or financially disadvantage those with the least resources by perhaps convincing them to buy something that isn't effective. So that's another way in which inequalities can arise at the individual level, but also at the societal level, if Peter's robbed to pay Paul in a way that is not actually addressing the core societal inequality issue. Other quasi-deceptions out there relate to the misuse of personal data for things like advertising from health apps. You may have seen the news in the last few days talking about a scandal of some of the period tracking apps, where data is being not only used to market products. We've known about that for a while. This has been a big problem. A lot of these apps send their data up to Google advertising, but they actually can be misused in more kind of nefarious ways. For example, in the United States, women are being made anxious because their data from these devices are being potentially shared with pro-lifers who in some cases can be quite violent, and they're potentially putting their lives at risk as well as their data. So things have consequences. And again, one would hope this new European and UK legislation will begin to tackle that. But again, create inequalities in terms of those harmful consequences for individuals. And those individuals who may be harmed the most may be the ones who are least empowered and able to select the data sharing preferences, for example, they may need to, or maybe less able to submit a data subject access request if they feel their data has been broached. So these are important new kinds of inequality we are not properly tackling. Another kind of deception is the framing of the uses of all this data for research and public benefit. And much of it is for public benefit. That's very true. But often it's being used for academic benefit or for commercial benefit or for other kinds of benefit that are not directly of advantage to the individual. So that is potentially an issue there. And likewise, all of this data can be used to create data profiles, which again, can have benefits and can be used to encourage people to perhaps pay more attention to educational awareness-raising activities in certain areas where there's known to be, excess obesity, for example. You could spend more time advertising healthy options in those areas, for example. But it can also be used to in more coercive ways, this sort of nudge intervention where it's not quite clear why you're receiving a message, and these are known as persuasive interventions, persuasive data-driven interventions, which some people may feel are manipulative and is an issue I think we probably need to open up. And likewise, data-driven clinical decision-making, so the use of an algorithmic tool, for example, to make a decision about who gets a ventilator, for example, and who doesn't. It may be based on data and evidence that may say, well, this person's more likely to benefit, therefore you'll get more bang for your buck in the pandemic if you put this person on the ventilator because they're more likely to gain. Now, that may be rational, but it also is a symptom of rationing, and it could disadvantage those who don't meet the profile. And we did hear about that quite a lot in the early part of COVID, for example. So we need to avoid mislabeling things data-driven when we really mean rationing-based. And if they are rationing-based, then we need to point out that people's data are being used to ration things to them, and just have open conversations about whether that is actually a sensible thing for societies to do or whether that's unacceptable. The next issue, and I suppose this goes without saying, the next D is diversity. And when we think about inequalities, they're often to do with unfair provision of services or treatment of people of different genders or ethnicities in particular, or particular locations as well, leads to a lot of issue. And we know that women and certain ethnic groups are underrepresented in much of the clinical trials literature, which means there's less data about them. And this creates a challenge for evidence-based and data-driven health. And of course, this can find its way into digital health apps and decision tools, including this artificial intelligence and so forth I mentioned earlier. If your sources of data are not complete or accurate, or do not represent those groups, then you may find the decisions that the advice that's computed from them may not be applicable to everyone equally and could lead to the under or over treatment of a particular group, for example. So I think this is a challenge. One digital health app I looked at not that long ago, for example, was if you put in, it was a chatbot, and it was supposed to be very artificially intelligent. And if you put in the same symptoms for heart symptoms and classified yourself as a man, it came out with an advice to seek medical attention. If you put exactly the same symptoms in and you were classified as a woman, it recommended anxiety treatments, or it suggested you might be feeling anxious. So, and this, of course, is a classic sort of hysteria hypothesis of heart disease, and really, it was quite shocking at the time. They've improved that now, but nonetheless, it was tracked back to the fact that those studies from which the evidence has been gathered, and on the way in which the algorithms have been generated based on that data, didn't represent women, or not sufficiently to give them good data. So, and that has been improved now. There's new data, actually, some of it coming out of Edinburgh University's heart research community. So that's really great. So that's just one example. And I've mentioned that already. So diversity affects data too. And the other big D is disruption. This term is being used a lot in digital health. Digital health is disruption, and of course we've got COVID that's disrupting things. All sorts of innovations are disruptive. Big policy changes are disruptive. But there's a lot of disruption going on in the healthcare service at the moment, irrespective of digital health, and that's the workforce crisis, for example, particularly in primary care. And so these new disruptions are being contemplated using technology. So a key area is digitizing doctor-patient interactions through telemedicine, which we've had a lot more experience of in the remote and distant world of digital health. But also using apps and trackers, or giving them to patients so they can have more control over their health monitoring. And other things like using digitally informed triage systems by telephone to sort people into the people that need a clinician, or maybe need a nurse, maybe need a psychologist, or who can actually be treated with a robot, referred for self-help using an interactive screen, for example. And this is the so-called digital first approach that has been advocated by people like Matt Hancock. And it sounds very good in principle, but consider the inequalities that may have a place here. Such approaches, they may, on the upside, let's think on the upside first of all, they may avoid the problem of people not wishing to consult because they're embarrassed. I had a very good case example recently from a chap called Bob Gann, who was working on with homeless people, and he discovered that if he was talked about this anecdote of this disheveled, smelly guy who was homeless and was reluctant to seek healthcare because he thought people would judge him. And when he was given a mobile phone or to be able to do it, he was able to set up appointments and things, and it removed the friction and it enabled him to seek services. So that tackled inequality. So in a sense, there are opportunities here. But at the same time, some of these tools may act as a deterrent for those who are more used to using face-to-face care, like the elderly, or people unfamiliar with technology, or people who lack their own sense of empowerment and entitlement, and they want the doctor to tell them what to do. And so this could create new forms of inequality we are unclear on. And they can also take away some of the benefits of in-person and continuous care, such as knowing your doctor, for example, and they're knowing your family history, can help them to perhaps unwinkle symptoms out of you that you might not have been able to surface or articulate if you were communicating electronically in some way. So there are downsides, and I have a paper discussing this, which I can reference later. Another big disruption is personalized medicine. Now, initially, this was all about using people's genetic profiles to help tailor their treatments, particularly the medicines that they use. But in practice, it was found to be unaffordable. And so we moved on to stratification methods, which is looking at sort of groups of people for which things might work better. But I think the other kind of in this field, the other kind of, and this links to the last point, insight that's emerged is that really the best form of personalization was the personalization you had with your family doctor before. They knew you, they knew your family, you had your history, and they could tailor care to you. So that's I think there's more insight into that personalization, that social value of that social information, if you like, being as beneficial as some of this genetic information. So, but again, I'll come back to this issue of genetics shortly. Oh yes, I'll mention it just now. This takes me on to this question of sharing of genetic information. Now, genetic information is the most personal information we've got. It's also highly predictive of your health conditions and therefore quite useful. And now people are sharing more of their genetic information, either as part of big research projects or because they've been asked to as part of their own care, for example, if it's thought to be a genetic condition. But they're also regularly sharing their genetic information for fun on things like ancestry apps and other kinds of 23andMe and other sorts of health apps. And they may be surfacing some insights that might be useful for their own understanding of their own health and wellness and that of their family. But we also are running into potential problems, not only because we're not quite sure about the privacy of that information and who could misuse it, for example, an insurance company, but also how that information and other sorts of information could be used to create almost a genetic class system. Are we giving too much away? Will we have a risk of creating a more dystopian genetic class system, or will we be able to use it to create a more enlightened, fair, and lateral society? These questions remain unresolved at the moment. Nonetheless, in the case of disruption, we can soon be expect to be treated by AI, or at least by clinicians or technicians who rely on it to aid their decision making. And as new generations of digital natives emerge, obtaining health advice, diagnosis, and arranging treatments using mobile phones will become just as common and as desirable as booking your train tickets or searching for products on Amazon, and does have potential. But we are seeing a slow disruption in that alongside some of these other big disruptions. Now, I've squeezed two other Ds together here, and they're around democracy and dialogue. And you can see they naturally follow from some of the issues and concerns I've been speaking about. But let's think about some positive sides of this. Crowdsourcing is a form of digital engagement and participation, and almost a form of democratic engagement. Now, we can crowdsource people in developing collective health intelligence, and this has been used in various contexts. I studied it back in the context of the Zika crisis, for example, but then it subsequently has been used in coronavirus, things like the Zoe symptom tracker app. People willingly participated in sharing their data on their symptoms and other aspects of their health and conditions using this app. And that created an almost democratically created database, if you like, of participating consented people. And that created also research insights. So there are opportunities to use other forms that are perhaps, very participated and democratic. And likewise, there are many different types of websites that people have set up, like Patients Like Me has been going for very many years, which was set up by individuals who were suffering from a rare health condition. And they got together with other people like them and also clinicians that helped them eventually develop this very successful network, which eventually ended up doing lots of research and innovation and discovering new drugs. Amazing. I've also been looking at hoping to interview someone soon around the development of the artificial pancreas, which was regarded as a kind of low cost benefit innovation by the tech community, but was driven by the patients themselves. So patient and consumer and family power, really important in developing some of these tools. So there are opportunities for people to take action and actually shape this field, just as there are opportunities to engage people. And if we can engage people in the lower socio-demographic groups, engage them in a way that's accessible and fun, actually, and gives them something back, then we'll also have other benefits, I think, in terms of engaging them with healthcare more generally and improving their empowerment over their own health, but also feeling they've got a stake in society too. I mentioned social media. That's just sort of something that happens naturally, and it is helping to surface health insights. We've looked at it in the context of asthma, diabetes, lung disease, and it does help to surface insights, and it's being used a lot to do things like pandemic tracking, for example, and also looking at public attitudes to things as well. Is it acceptable for my lockdown in this area, or is it unacceptable? Do we think the police have been too heavy-handed in intervening, for example? So social media can provide very good insights, and it's not, governed by anybody in particular. And as a result, it again could have potential to be more lateral, but it also has those downsides. And we have seen the use of strategic disinformation about COVID being targeted at those of either lower socioeconomic status or of particular ethnicities and age groups in order to disrupt the government's pandemic response. And I think we're going to see more and more of that. It is a form of warfare, some would say, and malice, others would say. But this is a major risk, I think, for citizens using social media, and we are likely to see, and World Health Organization is actually I was involved in this, was currently working on this big program called for supporting managers on infodemic governments and public health bodies in infodemic management in order to intervene and stop this from being so impactful, and to understand some of those influences and ways to diffuse people's entrenched beliefs once these earworms have got to work on them. I think the other issue about democracy and dialogue is crucial around the design of digital health tools, which, as I mentioned before, can also be a source of inequality. If you don't have the skills to use something, or if it doesn't actually represent your life, or it doesn't fit in with your lifestyle, you're going to be disengaged with it. And there's long-standing research and evidence from fields outside healthcare, not within them, that co-design with consumers and patients can produce more acceptable, desirable, and usable tools. But we do have gaps in engaging people from excluded groups. And this is where the problem lies, because very often people are invited in to do citizen-centered consumer engagement, and they're middle-class people with time on their hands. And this is not necessarily representative. So we have to reach out and do more work. And there are various ways in which you can do that. And likewise, open dialogues around digital and data are needed to find the right balance of benefit and risk, and to surface some of those concerns and anxieties around stigma, discrimination, and inequality. And likewise, we need to work with communities to negotiate how digital insights should be used to inform the provision of services in order to level society, rather than just imposing those activities on them. And as part of this, we could utilize online and digital tools, digital democratic tools, platforms that allow you to engage people and for them to give their own opinion. And we also need to be open about public spending on digital health technologies and the opportunity costs of financial waste in things like NHS Test and Trace, which has been much criticized, for example. What other uses could that money have been put towards, and what benefit for those at the in excluded groups or across society could have been brought from that money? And we need to be open about the twin sides of digital innovations. For example, I mentioned earlier a risk scoring tool that can be used to discriminate against someone as well as to help someone else. And sometimes there's a fair case for doing that people could be willing to accept when it comes to finite resources, but in other cases it may not be acceptable. So more need for democracy and dialogue for good and for avoiding bad. So just a few conclusions there to summarize all this. Digital health holds great potential as a leveler, but digital inequalities combined with other social, geographic, and educational inequalities will determine whether it succeeds. And without attention to these other factors, new tools available via the internet or on personal devices or driven by data about individuals, communities, and societies may improve the health, well-being, and empowerment of people whose health status, lifestyle, and access to care are already optimized, but maybe not those who are less health wealthy. So I like to think of health wealthy, that there's the health wealthy and the health deprived, and they may then widen this divide. Lessons for the pandemic have been useful in this and are being forward. And indeed, the United Nations Secretary General has called for a new social contract for a new era to tackle inequalities, as part of which digital is represented. I know that there are other initiatives like this also in the UK, and hopefully new research that can be done with Manchester to take that forward. So that was quite a lot of information, and I'll just conclude there and thank you for listening.